Let's see the T staging of carcinoma rectum. So T1 stage is invasion of the submucosa only, like here. Okay, the lesion is situated just in the submucosa. T2 is invasion of muscularis propria also. So here this is the muscularis propria layer, and the lesion here is involving the muscularis propria also. So this is T2 stage. T3 stage is invasion of adjoining. So this area is the perirectal fat, mesorectal fat. So the lesion is seen invading through the muscularis propria into the mesorectal fat. And this T3 stage is further subdivided into A, B, and C, D. A is extension into the mesorectal fat for less than 1 mm. Okay. B is 1 to 5 mm. C is 5 to 15 mm, and D is more than 15 mm extension into the mesorectal fat. Fourth stage T4 is also divided into A and B. A and B. A is invasion of the peritoneum and the peritoneal reflection. B is invasion of other organs or structures outside the mesorectum. For example, the pelvic organs, the striated or the skeletal muscle, for example, the external anal sphincter, puborectalis, levator ani, obturator. All these are involved in T4B stage. For example, any fat in anatomical compartment outside the mesorectal, for example, obturator, ischiorectal, and all these. Okay, so this is the T staging of carcinoma rectum. And I think you already have watched the part 1 of the video series. And if you haven't watched that, I'll recommend you to watch that video first. Because we are going to discuss about each of the subtopics that we have discussed in part 1. Okay. So point number 1 is extent of rectum, and that we know from sigmoid colon and involving the anal canal. Okay, knowing this is important because the sigmoid colon CA are managed by upfront surgery, while carcinoma rectum has differentiated treatment protocols. For example, if the patient is like low risk, okay, this involves the T1 and 2 stages, the patient undergoes total mesorectal excision or even local excision. While in intermediate risk patient, for example, the T3C and D stages, short course neoadjuvant radiotherapy is given to the patient. And if the patient is categorized as high risk, in like for example T3C, D stages and T4 diseases, patients are given long course neoadjuvant therapy, chemoradiotherapy, and then MR is repeated for restaging. Okay, so this is a differentiated treatment protocol according to the risk, according to the TNM staging. So what's the standard surgery for CA rectum? We all know that's TME, total mesorectal excision, where the surgeon removes this rectum, adjoining mesorectal fat containing the lymph nodes and vessels, and the plane of resection in total mesorectal excision is this mesorectal fascia. Okay, so most of the time surgeon tries to preserve the anal sphincters and the continence. So this type of TME is known as the LAR. Okay, but if the tumor is like involving this anal canal also, then sphincter preservation is not possible, and what patient undergoes is APR, that is abdominoperineal resection, and the patient is left with permanent colostomy because the anal canal is also removed. So we have to recognize the involvement of the anal canal. So involvement of external anal sphincter, levator ani, puborectalis link constitutes T4B disease. We already have seen. For example, in this case, here is the tumor that is seen involving the right-sided internal anal sphincter also. Again, in this case, this is the tumor which is seen involving the bilateral internal anal sphincter, left-sided external anal sphincter, and the pelvic floor muscle is also involved. So involvement of external anal sphincter, puborectalis link, levator ani constitutes T4B disease. But involvement of external anal sphincter and intersphincteric space is not in their involvement does not affect the T stage categorization, but that must be described if their invasion is present. One thing you must understand that definition of rectal versus anal canal cancer primarily depends on underlying tumor histology, that is the HPA report, because CA rectum can grow caudally to involve the anal canal, and CA anal canal can grow cranially to involve the rectum. CA rectum staging is not applicable to CA anal canal and vice versa because histologically they are different. Okay, CA rectum is adenocarcinoma while CA anal canal is squamous cell carcinoma, and due to this different histology, their response to treatment is also different. So we have to use the HP report before reporting the case. Okay, we cannot give TNM staging of rectum for CA anal canal. So you must have to start with the histology report if lower rectum and anal canal is involved, that whether we are dealing with CA anal canal or where we are dealing with CA rectum. So because there are differences in the TNM staging and the treatment offered for these patients. Okay. So next is the rectal wall layers. Rectal wall layers. T1 stage is involvement of the submucosa only, while 2 is involvement of the muscularis propria. But MRI is unable to differentiate T1 from T2, and that's why they are often clinically reported together as clinical T1 or 2 stage because of the two layered anatomy. For example, here we can see a lesion, but the outer T2 hypointense muscularis propria is maintained, means the lesion has not invaded into the adjoining mesorectal fat. It's still contained within the muscularis propria. So it's clinical T1 or 2 stage. Here also, this is the growth, but again the T2 hypointense muscularis propria is still maintained. So this is clinical T1 or 2 stage. Involvement of the mesorectal fat is categorized as T3 stage. Okay. For example, here this is the growth, and this lesion has invaded into the adjoining mesorectal fat from like 1 to 4 o'clock position. We have to give in our reports the smallest distance. Like this is the tumor, we have to mention in our report the smallest distance between the mesorectal fascia and the tumor. This smallest distance has to be given in the report. So this is the T3 stage. For example, it is further subcategorized into A, B, C, D. For example, this should be the outline, but tumor has grown till here, up to 5 mm. So this is T3 AB stage. This outline should be here, but it has grown for 5 to 15 mm, so T3C stage, and here it has grown more than 15 mm, so D stage. Okay. Please know that sometimes it is very difficult to differentiate the true perirectal involvement versus the desmoplastic stranding in T1 and 2 stages. Means it's a source of overstaging when there is desmoplastic stranding in T1, 2 stages, and they are overstaged as T3 stage. So we have to keep in this mind. Okay. So next is the mesorectal fascia. So MRF is considered as involved when tumor invades the MRF directly. For in this case, the tumor is directly involving the MRF, so it is MRF positive. And also, when the margin between the tumor and the MRF is less than 1 mm, MRF is said to be positive. Okay, so this is MRF positive. For example, here the tumor is very much distant from the MRF, so it is MRF negative, T3 like A or B disease. But here, this tumor has involved the MRF itself. So this is MRF positive case. Okay. But recently it is also proposed that this criteria applies just not to the primary tumor, but also to the EMVI, extramural venous invasion, any irregular lymph node, and any tumor deposit that are seen invading or within 1 mm of the MRF. Okay. If these things are also within 1 mm of MRF, MRF is said to be positive. Okay. So the MRF should be reported as involved in case of less than equal to 1 mm margin from either the primary tumor, extramural venous invasion, irregularly enlarged tumor deposits, or irregular lymph nodes. Okay. So we already have discussed in our part 1 of this video that mesorectal fat is teardrop shaped, capacious in the center, and very narrow at the top and bottom. Also, this mesorectal fat is thinner on the anterior side than on the lateral and the posterior sides. Thus, there is close relationship between the anterior rectal wall and the organs present here, like prostate, seminal vesicle in males, vagina and cervix in females. Okay, because of this anatomical difference. Also, we already have said that mesorectal compartment tapers towards the lower end. Thus, any tumor that is located in the distal rectum are at higher risk for MRF involvement because of this anatomical variant. Okay. So, if MRF is involved, then patients are stratified for neoadjuvant therapy to downsize the tumor and thus increasing the chance of tumor-free resection margin, thus decreasing the local recurrence risk also. And also there is one term, that's circumferential resection margin, CRM. Circumferential resection margin is a term used to denote the standard plane of excision of total mesorectal excision used for resection of rectal cancer. And the anatomical correlate is this MRF. Um, so distance between the tumor or the satellite deposit and MRF on MRI is predictive of involvement of CRM and likelihood of incomplete resection at surgery. Okay, so if less than equal to 1 MRF distance is there, MRF is considered to be positive, and CRM would turn positive on pathological report. Okay, CRM is a more of surgical and pathological term. What the pathologist report in their post operator specimen, whether the surgeon that has given the specimen has negative margins or not. Note that the mesorectal fascia is only considered CRM for the non-peritonealized portion of the rectum, that is below the level of anterior peritoneal reflection. Okay. The remaining was T4 stage disease. For example, in this case, there is invasion of the external anal sphincter also. Okay, there is invasion of the left external anal sphincter and the invasion of this pelvic floor muscle, that is levator ani muscle, that is T4B disease. Again, in this image, the lesion is seen extending beyond this level of mesorectal fascia into the adjoining obturator compartment, and also there is involvement of the vagina. So all these are T4B stages. Okay. For example, here also, this is the line of MRF, and the lesion is seen extending outside the mesorectal compartment into the adjoining another space. So this is also T4B disease. Okay. So next is the anterior peritoneal reflection. Like, you must know that MRF and peritoneum are two separate anatomical structures, and separate recognition of their respective invasion is important on imaging. Okay. So like here, the T2 hypointense line of muscularis propria is maintained, suggestive that the anterior peritoneal reflection is not involved. However, in this case, the T2 hypointense muscularis propria is not seen, and the anterior peritoneal reflection lining is definitely involved. Okay, it's not like that. If peritoneal reflection is involved, MRF cannot be involved, and vice versa. Let's see this. So here, the MRF is spared, but the anterior peritoneal reflection is involved. So T4A disease, that is above the level of anterior peritoneal reflection. For example, below the level of anterior peritoneal reflection, there is no anterior peritoneal reflection, and here the lesion is seen involving the MRF. So this is T3 MRF positive. And in this case also, above the level of peritoneal infection, the lesion anteriorly has involved the anterior peritoneal reflection, and we all know that above the level of anterior peritoneal reflection, mesorectal fascia is present on the posterior aspect in the high rectum, and posterior and lateral aspect in mid rectum, as discussed in part 1 of this video. So here anteriorly, like peritoneal reflection is involved, posteriorly MRF is involved. So this is definitely, this will be T4A disease and also MRF positive. Okay. So this is peritoneum and peritoneal reflection involvement. Next one is the blood supply and the extramural venous invasion. So the venous drainage of upper 2/3 of rectum is into the portal circulation via the superior rectal vein, and the venous drainage of the lower 1/3 of rectum is into the systemic circulation via the inferior and the middle rectal veins. As the upper 2/3 drains portal system into the portal system, so hepatic metastases are very common, while the lower 1/3 cases, there are less chances of hepatic metastasis. Instead, we find pulmonary metastasis. Okay. So extramural venous invasion is the invasion of the small, thin, wispy, serpiginous venous channels that are seen emerging from the rectal wall, and these should be ideally T2 fluid. But when the tumor signal extends into this venous branches, the vessel is expanded and the vessel contour is disrupted. These are all the signs of EMVI. The vessel will follow the signal of the tumor, the vessel will be expanded, the vessel contour will be disrupted. So this is extramural venous invasion, and this is definitely like a bad prognosis for the patient. Okay. These patients have more chances of recurrence, more chances of metastasis, and definitely decreased survival for the patient. Okay, we have discussed all the basics now. Now let's look at the reporting format for CA rectum. So we have to give the morphology of the CA rectum, whether it's polypoidal or whether it's sessile. And this sessile can be circular or semicircular, like this is the polypoidal. This can be like a circular circumferential. This can be like semicircular, and ulceration can be present. Okay, next one is the morphology. That can be solid or mucinous. Solid is T2 intermediate, while the mucinous is T2 bright. Okay, and it can be mixed. And there is another variant, that is signet ring, which is of very bad prognosis. So this is the morphology of polypoidal, sessile, solid, mucinous. Next one is the location. We have to mention that whether it is involving the high, mid, or the low rectum, we have to give the distance of the tumor, its highest extent from the anal verge and its lowest extent from the anal verge or anorectal junction. Then O clock position, for example, in this case, this semicircular growth is along 10 to 4 o'clock position clockwise. And we also have to mention that whether this thickening is above the level of anterior peritoneal reflection or below the level of anterior peritoneal reflection. We have to give the size of the lesion in terms of the craniocaudal length and also the maximum thickness or the size of the lesion, for example, if it is polypoidal. So this is the morphology, location, size. Then T staging, we have to give the T1, 2, 3, A, B, C, D, and 4, A and B. We have to give MRF is involved or not involved by mentioning the shortest distance between the tumor and the mesorectal fascia. Next is the EMVI. And these nodal and metastasis we'll discuss in part 3 of this video. So for example, this is the circular growth of C rectum. This is the semicircular growth of C rectum. This is the T2 hyper intense mucinous variety. This is the T2 intermediate solid morphology. Okay. What are the bad prognostic signs for C rectum? So the bad prognosis features include the EMVI, the mucinous histology, okay, and the status of MRF positive. Okay, so with this, I think the T staging of carcinoma rectum is clear to you. And now let's see you in part 3 of this video. If you have any doubts, you can ask me in the comment section. And thank you so much, everyone. Good night.